clinical studies to inform effective interventions aimed at reducing the burden of HIV and related diseases on women, men, and families. I also have the pleasure of introducing Kalisha. So Kalisha Bhimraj is an independent data analyst and researcher specializing in HIV prevention, hepatitis, maternal and child health, and epidemiology. She collaborates with academic and clinical teams internationally, providing data management, analysis, and insights for clinical trials and public health research. Kalisha has worked extensively on studies evaluating pre-exposure prophylaxis adherence, pharmacokinetics, and implementation among pregnant and postpartum women in South Africa. I'm very excited to hear both of you talk, and I'm going to hand it over to the two of you now.
Thank you so much, Haley, for the great introduction, and good morning to all of you. I know it's early there, so we'll try to keep this as exciting as possible, and we're going to share from our experience. And I'm happy to really have Kalisha here as well. Kalisha, I don't know if you want to put your screen on and say good morning to everyone before I get started.
Yeah, hi everyone. Thank you so much for the introduction. I'm really excited to be here, so thank you for having me.
Thanks, Kalisha. And so I'm going to go through some slides that are going to be talking about, can everyone see my screen? Yep, okay. So I'm going to be talking about reimagining global health training and talk about my experiences from UCLA and the University of Cape Town in South Africa, where I work with Kalisha. And then Kalisha's really going to talk through her experience working with UCLA students, residents, fellows, all of you, and really what we've learned. So I'm going to start with a positionality statement. I'm a white US-born cisgender educated woman. I live in South Africa with my family. I also acknowledge the systems and structures which afford my unearned privilege. I'm committed to improving my understanding and practice around decolonizing research, guided by feminist and decolonizing perspectives, and by people with lived experiences different from my own. And so this positionality statement, I encourage everyone to really think about when you're presenting and when you're talking about data that is different than your own life, because it really helps us to be aware of our own biases, perspectives, beliefs, and assumptions in our work. So for today, we're going to talk about reimagining global health. And this is such a pertinent discussion regarding what's happening right now and really undermining global health, especially from the US perspective. I'm really going to talk about what's the problem, how is this problem realized in the field. And I'll talk about examples of UCLA and South African experience with the Global Health Program, our ongoing research and collaboration here in South Africa, and steps that I'm working on with my team to address global health inequity in our work, which is fundamental. In this elephant in the room, you can see the elephant in the room, which I really like. This cartoon is power and privilege. In every room that we're in and every room you're in, the elephant in the room is the power and privilege that we hold. And around that, we really have patriarchy, racism, lack of DEI, especially now, white supremacy, coloniality, and capitalism that are taking over. And so just to start out, can you imagine this? Two masters in public health students from University of Cape Town in South Africa land in Los Angeles for a 2-week visit. They visit the campus, talk to some professors, visit some local organizations and schools to learn more about gun violence on campus, and they read a few reports. They write up a report with recommendations on how to fix gun violence in the United States. They then publish their paper in the American Journal of Public Health. Hard to imagine, right? But the inverse happens every day, where people from the States or from the North come to the Global South for a couple weeks, read a few reports, and then write, recommendations as if they're experts. So why are we reimagining global health today? Global health keeps failing on equity. And so the equitable response is not delivered in reaching people that need health services the most. The key reason is that the field inherently that we work in is inequitable. The global north that I represent and all of you represent are privileged. We hold power, and it doesn't really force us to change the structure of power. And to bring equity, global health must evolve from a saviorism to an allyship. And I'm going to talk about that in the work that we're doing, is really being allies with the colleagues that we work with in the Global South as experts in the field, and not as needing to be saved or needing to be told what to do. And so really it's changing from a colonial perspective to an allied perspective. There's a lot of obstacles to shifting this power, but it is possible. But no change can happen without a demand. And so it really behooves all of us to start demanding this change. So at the end of this presentation, there's a few articles that I'm going to cite that I recommend you read. This is a slide from Professor Marupai from McGill University, and Tracy and I went to his class about rethinking global health or restructuring global health, and he published this in The Lancet 5 years ago. And the question was, will global health survive its decolonization? And what they wrote was that global health is a discipline that holds within itself a deep contradiction. Global health was birthed in supremacy, right? But its mission is to both reduce and eliminate inequities globally. So it's a really interesting article perspective to take about how do we do it if inherently global health was born from this colonial perspective. So first, where are the global health organizations? First of all, I want to take questions anytime. So if anyone has questions, can you just raise your hand and I'll stop. I'm happy to take questions as we go. Is there any questions before I get started on the global health organizations? Okay. Feel free to interrupt or raise your hand. So you can see in this map that 46% of global health organizations are in Europe, 38% are in North America, and only 7% are in sub-Saharan Africa. And you can see less than 2% are in MENA, Middle East and North Africa, or Latin America and Caribbean, and Asia is only 5%. Where are the leaders? Who are the leaders? Global Health 50/50 is an organization that evaluates this every year. And for every 20 global health leaders, 14 are male, most are male, and 17 are nationals of high-income countries. Only 3 are nationals of low and middle-income countries. So the patterns of privilege prevail. Where does the money go? So this, from the NIH, Wellcome Trust, USAID, Bill and Melinda Gates, you can see the statistics of 70% of Fogarty grants go to US and high-income country institutions. The Wellcome Trust, which is a UK equivalent of NIH, 73% of total international grant portfolio supports UK-based activities. And 80% of USAID's contracts and grants go to US firms. Even with the Gates Foundation now, it's no longer Bill and Melinda Gates, but even with the Gates Foundation, only 10% of funding goes to the Global South. Then we're looking at dissemination of global health research. Is who is publishing? There's been several articles published recently in BMJ Global Health, really addressing this question of dissemination and publishing of global health research. So the first one here that I reference at the end is a systematic review of collaborative health and research from 2014 to 2016, authorship equity from the UCSF, and who is telling the story, a systematic review of authorship. Overall, 16% of UCSF affiliated articles had a low and middle income country researcher as first author, 19% had an LMIC researcher as second, and 14% as last author, which is completely unacceptable. If you look at who's editing, so who edits all of the publications where we publish, you can see that non-white scientists appear on fewer editorial boards and spend more time under review and for fewer citations, which was published just a couple of years ago. Global Public Health published an article about challenging the old boys club in academia. And then there's another commentary. So in 27 global health journals, 303 editors, only 40% were females, 68% were based in high-income countries, a third were based in Europe, a third were based in North America. And among editors-in-chief, it's even worse. So those in charge, only a quarter were females, and 73% were based in high-income countries. Conferences. We look at conferences. I'm sure many of you have attended conferences. Where are the conferences held and for whom? Last year, there was a conference in Canada, an AIDS conference in 2022. There was another AIDS conference in Canada. And you can see the picture on the left where the entire panel focused on African researchers was empty because they couldn't make it to the conference. The Africa CDC had trouble getting to Germany even for the World Health Summit. And there's a lot different people that can't make it to conferences because of the visa issue. Again, the global health perpetuates really liking to think about global health as being charity or philanthropy, giving aid, donations, development assistance, saviorism, dependency. The global South when in research really focuses on human rights. They want equity in research and equity in delivery of health services and social justice, reparations, autonomy, respect, self-determination, and self-sustenance. So what's the problem if the privileged, like all of us, dominate global health? First of all, we lack lived experience. I grew up in California. I did not grow up in South Africa. Colleagues like I have today, Kalisha, who grew up in South Africa, have far more lived experience that enables me and us to develop better health interventions and health research than if I were come in and do it by myself. Our privilege prevents us from seeing things clearly. So our privilege is actually a bias. We're away from the real problems and solutions, and we make mistakes even if our intentions are good. We will center ourselves, and we can stop feeling generous with no accountability. And then in the end, because of all of these issues, we actually failed to address the structural issues in our research. So because of all of this background understanding, and I encourage you to read some of these papers that I referenced earlier, we are really actively thinking, how can we rethink global health training? Is there any questions about the data I shared earlier before I get into our rethinking slides? Okay. So let's reimagine this. Two master's students from the University of California land in Cape Town for a 2-week visit. They visit the University of Cape Town campus, talk to some professors, visit some local clinics to learn more about HIV prevention, read some reports. They then write up a report and recommendations on how to prevent HIV in South Africa, where we're the largest population of people living with HIV in the world. They publish their paper in Lancet HIV. This happens all the time. A lot of the articles that I'm sure you'll be reading throughout your career happens like this parachute research that we'll talk about. It's very common. What can we do from the global north? So this is another paper that was written by Madhu Pai and really talking about allyship. And so I mentioned allyship earlier. So the Anti-Oppression Network defines allyship as an active, consistent, and arduous practice of unlearning and reevaluating, in which a person in a position of privilege and power seeks to operate in solidarity with a marginalized group. They talk about it's not an identity, it's a lifelong process that I hope we can all embody of building relationships based on trust, consistency, and accountability with marginalized individuals and our groups. It's not self-defined. Our work and our efforts must be recognized by the people we seek to ally ourselves with. So let's talk about an example of collaboration in my work in South Africa, preventing HIV in pregnancy and postpartum. So Kalisha is here on the right, and I'm standing next to her on the left with our colleagues from South Africa, Rufaro and Sumaya, who are working on our studies, and Nafisa Wara, many of you might know, was here on the Global Health Program Discovery Year last year. And she also had a GloCal fellowship. So to go back to our research, there's a high HIV incidence during pregnancy and breastfeeding. In a meta-analysis of 37 studies, the estimated average HIV incidence rate among pregnant and breastfeeding women was 3.6 per 100 woman years. Incidence was associated with age, partner HIV status, and calator time, so it decreased over time. And so you can see the stratum-specific rates below for pregnancy only, breastfeeding only, and pregnancy and breastfeeding, which were exceptionally high. Why do we have this increased risk during this time? There's both biological and socio-behavioral factors. So our research is really trying to understand both the biology and the socio-behavioral. First of all, the hormone changes, increased estrogen, progesterone, genital tract expression of cell receptors, immune adaptations, including activated innate immunity, suppressed adaptive immunity, and alterations in the vaginal microbiome that some of our team has actually published on. STIs, we've done a lot of research as well about high prevalence and incidence of STIs, and including bacterial vaginosis. Postpartum trauma, micro and macro, and breastfeeding can lead to low levels of estrogen. Sociobehavioral factors include condomless sex, having a sexual network of more than one partner. Intimate partner violence is quite common in our region. And then stigma really related to seeking HIV testing, treatment in terms of antiretroviral treatment and PrEP use. And substance use also increases the risk of HIV exposure due to the impact on sexual behavior. So this is something from the Global UNAIDS report from last year. And you can see here that globally, 1 in 4 infant infections are attributed to incident or new maternal HIV infections. In the region where we work in East and Southern Africa, 1 in 3 infant infections is attributed to maternal HIV. So there were about 29,000 infant infections from incident HIV during pregnancy and breastfeeding, and 16,000 infant infections in East and Southern Africa, which is about 60% of global cases. We started working on oral PrEP about 10 years ago when I arrived in South Africa, and it was not part of standard of care yet in South Africa. So I'm sure many of you have heard of oral PrEP. Oral PrEP is tenofovir and emtricitabine, so TDF, FTC in pregnancy. We've shown that it's safe to use while pregnant or breastfeeding with low concentrations secreted in breast milk. In our recent study, we found there were no difference in pregnancy and birth outcomes using objective levels of tenofovir diphosphate in blood in 500 women. And there's similar data from Kenya and systematic reviews. So just to say that oral PrEP is safe. There's new modalities that are coming out and differentiated delivery to really reduce barriers to daily oral PrEP use. First is injectable cabotegravir, which is an intramuscular injection every 8 weeks. Lenacapavir has just been approved by the FDA and is under review from our SAHPRA here in South Africa, the South African health regulators. It's a subcutaneous injection every 6 months. It's currently an investigational product here, but we're hoping it becomes commercially available in the next couple of months. The dapivirine ring is inserted into the vagina every 4 weeks. And I've included differentiated PrEP delivery that we're evaluating really to understand how best can we deliver each of these methods to women where and when they need it, including multi-month dispensing of oral PrEP, for example, pharmacy or community rapid queues, and use of self-testing for HIV for PrEP pickup. And so we're evaluating all of these different methods in terms of providing choice to pregnant and postpartum women. So one of our ongoing collaborations with our colleagues here at University of Cape Town is the potential benefits of cabotegravir, and we're updating this now with lenacapavir in pregnant and breastfeeding women. So without any PrEP, without any primary prevention in this population, there'll be 1.3 million new infections in South Africa in the next 10 years, including 100,000 in pregnant and breastfeeding women, 17,000 infants at or before birth, and 35,000 in children through breast milk. We used 3 scenarios where only oral PrEP was provided. They're CAB-LA, oral and PrEP, CAB choice. The model was informed by our South African data on both CAB-LA and oral PrEP, and the incidence reductions were significant. When we compare oral PrEP only 9% were reduced in pregnant and breastfeeding women and 9% reduced in infants. CAB-LA was about 40% reduction, and the choice maintained the same. So you can see here on the figure on the right that about 40% reductions in HIV incidence when there was a choice between oral and CAB injections. So Nafisa Wara, that I mentioned earlier, is a GHP research fellow last year. She evaluated long-acting PrEP acceptability in oral PrEP using pregnant and breastfeeding women. And she collated data from our PrEP PP, which is PrEP in Pregnancy and Postpartum study, and the Prima X study, which was in Kenya, and asked if injectable PrEP were approved as safe and effective for use, would you prefer to switch or stay on oral PrEP? And 75% in both countries agreed that they would prefer injectable PrEP over oral PrEP. 87% said they'd want to continue oral PrEP over the vaginal ring. So really more research is needed about barriers to vaginal ring use. Is there a question? If there's a question, you can go ahead. Okay. And then South African women were more interested in differentiated PrEP delivery than Kenyan women. So when we asked, do they want to get their prevention product outside of the clinic? So in the community or in their home, 59% of pregnant and breastfeeding women in South Africa said yes, but only 25%. So we're conducting an ongoing trial right now, Scope PP, which is a stepped care study to optimize PrEP effectiveness in a randomized control trial that we're getting ready to publish and disseminate later this year. I'm also collaborating with Desmond Tutu Health Foundation on Prepared to Choose, which is an ongoing implementation study in South Africa. The study enrolled young people in a community mobile van in one clinic, offering choice between oral PrEP and Cab-LA. They're also integrating lenacapavir, Yes2Go, I think it is the brand name now in the US, following choice counseling with the option to switch modalities at follow-up visits over 18 months. And through last year, 58 pregnant and breastfeeding women were in the study. Most started on injectable PrEP and only 27% started oral PrEP. Women reported that they liked the ease of use, long-acting protection. Only one participant was unlikely to continue due to injection pain, and 14% said that they would likely use the vaginal ring if approved for use in pregnancy and breastfeeding. The data collection is ongoing, and we're going to be presenting these results in the next year. This is an ongoing collaboration between myself, UCLA, and University of Cape Town on ongoing research. And there is opportunities for mentorship and training with the UCT and UCLA staff on the PrEP PP cohort, so the PrEP in Pregnancy and Postpartum, which is an R01 NIMH-funded study that recently ended by myself and Landon Meyer at the University of Cape Town. And Kalisha worked with us in the study as a data analyst and a data manager. This is an observational cohort of 1,300 pregnant women, and we counselors counseled women at each quarterly visit with follow-up through 12 months postpartum to evaluate the proportion of pregnant women who initiated PrEP, the proportion who were retained on PrEP, and the proportion who adhered over time and associated risk factors. This is a mixed methods evaluation that allowed women to start or stop PrEP at any time. The 1,200 women, 84% initiated PrEP at their first antenatal visit, and you can see some of the sociodemographic factors here. Median age was 26 years, gestational age 21 weeks. Most were sexually active and reported condom-less sex. And 54% did not intend to get pregnant, which is really important in terms of integration of contraceptive methods postpartum. A third were unsure of their partner's serostatus. 13% reported intimate partner violence in the last year, and 50% reported substance use in the last year, mostly alcohol. However, only a quarter had heard of PrEP before. When we evaluated persistence in PrEP returning for repeat prescription, you can see that over time, and the dark blue bars is pregnant and the light blue bars is postpartum. Once women gave birth, they were significantly less likely to come back, though the risk of HIV acquisition and transmission to the infant remains elevated, especially through breastfeeding. Yes. So this is some seroconversion data. Most seroconversion in our study happened in the postpartum period. As I mentioned, PrEP use was poor in the postpartum period. We had 1 pregnant woman and 15 postpartum women who seroconverted, and we had 2 infants that were HIV positive. PrEP use in seroconverters was mostly due to those who discontinued PrEP use. So 10 women had started PrEP but discontinued it, which is about 2/3. 4 women reported intermittent use, and 2 women had never started PrEP. So these are some of the barriers that we've published on, being logistical, forgetting to take PrEP, being away from home, logistics around collection, transport, financial barriers, pill-related side effects around PrEP, pill burden, especially during pregnancy and postpartum, and then sociocultural really around anticipated or experienced PrEP stigma, limited disclosure of PrEP use, and concealment. Then we moved from a clinical trial to an implementation science study, really to demonstrate that PrEP integration into antenatal care was acceptable and feasible. And we published these results with our colleagues in South Africa. And it was more challenging in the postpartum period due to that the mother doesn't always attend the well baby visits, and the focus is really on the infant versus the mother-infant pair. So we're exploring studies really to improve mother-infant visits together. So there's collaboration on bridging the gap. You can see there's several different publications here led by our South African teams and others, really to talk about universal PrEP delivery to everyone is as effective as risk-based delivery, just focusing on higher risk women in Kenya, focusing on the dapivirine vaginal ring acceptability and safety. Self-testing can be used safely for pregnant women. And then urine tenofovir tests can be used for real-time adherence feedback that we're using right now in our SCOPE PP trial. Safer conception interventions are improving to improve PrEP persistence, really to align contraceptive and visits around where people are seeking to get pregnant and PrEP use. And there's an urgent need for choice in this population. So we're working together with government. We're part of the government research groups on this, researchers, program managers, and NGOs, really to improve access to and counseling for effective PrEP use. So as a result of our trial, the guidelines changed, and the guidelines continue to change to ensure that pregnant and breastfeeding women have access to the methods and the counseling they need. We've also advocated for simplifying access through removing prescribing, lab, and drug access barriers, including differentiated and community delivery in the postpartum. We're advocating for rapid, cost-effective choice, including injectable PrEP, to improve effective use, and then improving health education and training in the community and among providers to encourage PrEP in this population to decrease stigma. So that was a long-winded way to go back to the Global Health Program. To go back to the Global Health Program, before I go back, I just want to see if there's any questions about our research before take it full circle. The Global Health Program really seeks, they say, to improve health equity worldwide. And so the Global Health Program at UCLA creates reciprocal long-term collaborations rooted in equity, trust, and mutual respect. Students, trainees, faculty, and staff work along colleagues around the world, like myself, on multidisciplinary education programs, clinical training, patient care, research, and public health initiatives. And GHP prepares medical students and trainees to advance health equity by providing them with knowledge, skills, and structural competency in global health. So again, I go back to Nafisa, who's third from left, who's a MS3, previous Fogarty International Global Fellow with our University of Cape Town staff, and she conducted a qualitative training to help with collection of her research and led to dissemination of several different publications with this team. What we seek to do, though, is we really try to bring in experiences so that they can be aligned together, the staff in South Africa with our staff at UCLA. And so you can see we really don't want people parachuting in and taking research away from what we're conducting in South Africa. And so UCLA to UCT, we have over 8 years experience, over 20 students and fellows. Fellows generally come in and students generally come in with great ideas and good intentions. They have strong opinions or hypotheses they want to evaluate, And we give them access to UCT resources, people, time, data, and even go forward to collaborate on grants and publications. Most students, faculty, researchers are excellent allies and work with our South African partners on analysis, clinical work, and other initiatives. Some, however, are not prepared to be an ally and require more mentorship and support. And this is why this training is key for all of you, because we want you to be in the latter group. We want you to be allies and seek out collaborative relationships when you come into the country with where you're going to be working. So what can we do better in our collaboration and learning to ensure reciprocity? For the University of Cape Town, Desmond Tutu Foundation that I work with, our learning and research. These are the 3 recommendations that we have, is really equity and authorship. So colonial science, also known as parachute or parasitic science, is an extractive practice whereby researchers, typically from highly resourced countries, do research and extract data on non-native regions or populations, and without appropriately acknowledging the importance of local infrastructure. Foreign researchers fail to establish long-term equitable partnerships. So some examples here is that PLOS, Lancet, and Cell Press now have policies to prevent parachute science and promote inclusivity in global research. Foreign researchers are required to complete an inclusivity in global health questionnaire, and Lancet now rejects papers from Africa that fail to acknowledge African researchers. The Royal Society of Chemistry also started a collective action and joint commitment for action of inclusion and diversity in publishing. Number 2 is we're striving towards true equity in training. The collaborators should prioritize locally derived and relevant solutions, be paired between high income and low income as many levels as possible, including principal investigators. Like I said, I work closely with my principal investigator here, the field teams, lab staff, trainees, and data analysis staff. We really want people to work side by side. And the budgets need to provide for paired funding for investigators, both from the high income and the low and middle income countries, for bi-directional travel, conference attendance, dedicated research time, so that it's not just us coming here, but also that our colleagues get to come to UCLA or get to come to the States for conferences, travel, and research. Collaborations should assign clear roles and responsibilities, and they must be done appropriately during the dissemination and publication phase. I'm not going to go through all of this because I want to give time to Kalisha to talk at the end. But really through each phase of the research, there's opportunities to advance equity. And I suggest that you take this QR code, read this paper, but it's also at the end of the presentation. So they give really clear steps about how to advance equity through the design phase, the implementation, analysis, and dissemination in your research. So what have we learned to date? We're ongoing collaboration to ensure funding, conference attendance for the UCT team to attend and represent at conferences. We have fully funded scholarships for our UCT team. We have Kalisha received a new investigator award, got to go to Croy this year to present data, HIV-R4P, as well as the South African HIV Clinician Society. There's Kalisha. We also need to bring new PIs to get their own funding. So I'm working with Dr. Alex Dvora at UCT to get some global health funding, and she has an application on going to a K43. Assign clear roles and responsibilities for all phases, making data analysis and manuscript writing tools and training available to all team members. So all of my team members have had the opportunity to publish papers and to learn more about either qualitative or quantitative training. And utilize local capacity in all roles, including data management, analysis, dissemination. So I think we're doing relatively well on the first one. In progress is really pairing UCLA and UCT trainees to learn and publish together. We're doing better on this. Longer training opportunities are better for learning, however. Shorter opportunities are more likely to parachute. We're giving opportunities to co-write abstracts and publications. So Nafisa, who I mentioned earlier, and Sumaya Dunn published a paper together and presented together at Croy in HIV-R4P. More effort really needed is to redefine significant contributions for sharing of first authorship. And then funding opportunities really remain limited, especially with changes now in the NIH that have blocked subawards and for funding to LMICs. LMIC partners must identify and lead research opportunities and solutions, and we need to connect our LMIC training to opportunities at UCLA and need additional funding and time to ensure that our UCT trainings and staff can do US-based training. So I'll ask you today, what can we do better to work together as allies? And I'll leave you with this quote. High-income country institutions like UCLA need to learn the lifelong practice of allyship that is building relationships based on trust, consistency, and accountability with marginalized individuals and/or groups. So I'm going to end here. That was a long slides, and I want to pass this on to Kalisha, who's going to give her experience. But is there any questions before I pass it on to Kalisha? Okay, over to you.
Thank you, Dvora. So I'll be sharing a little bit of my personal perspective and experience as a South African researcher specializing in applying data analytics of infectious diseases within public health. So a little bit about my background, my academic background. It's in medical science. I hold an MPH in epidemiology and biostatistics from the University of Cape Town and an MSc in anatomy and a BSc honors in neuroscience from the University of Pretoria. I'm originally from a small town called Ladysmith in KwaZulu-Natal in South Africa. And growing up there, I never imagined that one day I'd be contributing to research with a university like UCT or UCLA, or that I'd be here sharing my experience with all of you. And coming from a small town, global health always felt like something that happened elsewhere, something distant. And now to be part of that work and help shape it from a South African perspective is really something that feels both humbling and meaningful. I've spent the past few years working at UCT on studies, as Dvora had mentioned, focusing on PrEP use in pregnancy. And my journey into global health has been shaped both by opportunity and challenge. I was originally employed through UCT for an NIH-funded study where I worked on as the data manager. But when my position ended due to NIH funding cuts, as we're all aware of, I found myself unexpectedly outside the institutional structure, even though the research still needed to be completed. That's when Dvora, through UCLA, reached out and contracted me to continue on the same analysis independently. I'm truly grateful to UCLA for making it possible for me to continue contributing to this research. I don't know why my screen is jumping up and down. My camera is zooming in and out of me. But their support, UCLA support, allowed me to stay connected to the study and the communities that already had trusted us with their participation. It also reminded me that while institutional structures can shift, meaningful collaboration can still continue when people believe in your work. And on paper, it might look like a simple transition, but in reality, it made me think deeply about what global collaboration really looks like. I'm still doing the same scientific work with the same data, but the dynamics are very different. It showed me how our research systems are often built around hierarchy, where being in or out of an institution can shape access to funding, visibility, recognition, and even when the expertise and the commitment still remain the same and remain local. So what happened with the project also revealed something important. Sometimes it's not decisions made in South Africa that interrupt the work. It's funding shifts or administrative issues in the global north that ripple down and affect real people and communities in the global south. Participants, staff, and local researchers often bear the brunt of those disruptions, even though they're the furthest from the source of the decision. But this experience has also given me courage. working as an independent contractor made me realize that my contribution didn't depend on a title or an institution. It depended on my dedication. It inspired me to continue working as a data analyst and consultant, where I'm now independently contracted on several studies across Africa. So while I may have lost my institutional title, I haven't lost my role in research. I've continued to contribute meaningfully to teams across studies, helping move helping move the projects forward in ways that are still grounded in local understanding. And through this collaboration, I've also had the chance to work closely with UCLA students visiting South Africa, exchanging ideas and collaborating on studies with real world implementation and forming lifelong friendships, both professional and personal. I've also had the incredible opportunity to present South African data to international audiences and share insights from our work, as Dvora had mentioned, and represent the perspectives and people and communities of where the data comes from. So for me, reimagining global health means building systems that value this kind of flexibility and resilience, where collaboration is not extractive or temporary, but reciprocal and sustainable. It means ensuring that when projects or studies end, the people involved locally aren't left out of the next phase. It also means valuing intellectual contribution beyond institutional affiliations and ensuring that South Africans are not just implementers, but co-owners of research as well. The UCLA UCT partnership really does show this potential. And when collaboration works well, it builds capacity on both sides and produces meaningful and impactful research. But when challenges do arise, they remind us of how important it is to design partnerships that protect the people and communities at the heart of global health. I'm deeply grateful to be here today, not as a critique, but as a reflection on how we can keep evolving towards more equitable, inclusive, and sustainable models of collaboration. Thanks.
Thank you, Kalisha. That was great. I'm so glad that we can continue to work together. And I didn't bring up the problems that we had with NIH because I think that Kalisha really demonstrated the challenges that we've had with our ongoing US funding. So thank you for bringing that up and embodying all of the issues. Haley, do I hand it over to you for Q&A?
I think, yeah, we can open it up to Q&A of anyone in the room who has a question. And then I know Elizabeth has a survey I think that she's going to be sharing at the end.
I just want to say that Kalisha is a superstar. She's worked closely with all of our GHP students, fellows, residents when they come to Cape Town and is always willing to help with data analysis and work directly. We've published a lot together. Kalisha and I think we've published probably over 10 papers in progress and been published. And she got to focus on attending all of these conferences, was in Ghana earlier this year, San Francisco, at Croy. Where else did you go? Oh, Peru, Lima, Peru.
Yeah.
So we're really trying our best to make sure that it's not just myself and my team at UCLA. They get to go and present our data in conferences and manuscripts, but it's also our team on the ground. Any questions? I know that Evelyn asked a great question about cost. We're really fortunate that oral prep is free in clinics and that it's relatively affordable in pharmacies. Injectable prep is more expensive, but there's been some discussion right now about trying to get the lenacapavir or the Yeztugo to be about $40 a year through generic manufacturing. But for now, most products are free in the clinics, which reduces some of the barriers that we have, at least in the US, to getting PrEP, which is very expensive.
Hi, Kalisha, thank you so much for sharing your experiences. Actually, can everyone hear me?
Yeah,
Yeah, I can
yeah,
hear
we can
you.
Okay,
hear you.
I love it. Okay. Um, I was just wondering, what was kind of ways that your mentors have encouraged either you or your peers to come into the field of research? I know sometimes, at least for what I've talked to folks in other countries, is that research might feel a little bit walled off. It's like, okay, that's with the institution, that's with the, I guess, universities. How did you feel included within? I say, how did you start your journey and did you feel included in that initial phase?
Yeah, that's a good question. Thank you. So basically where it started for me was joining the MPH program at UCT. And a lot of the PIs like Dvora and other PIs in in the division, like Professor Lara Dugas, they were lecturers to some of our modules. So we got to interact directly with PIs and learn about their work. And there's opportunities that are structured within the MPH program. Um, where you need to do your mini dissertation, for example, and you have to reach out to these PIs and the people you meet along the way who come and guest lecture or take you for the modules, and you reach out to them and you approach them and you ask them if there's any opportunities. And I think it's just the way that the UCT program is structured, and from my experience, like Dvora and Prof. Dugas, um, they're very open to they're very open to collaborating and sharing their data and letting you do secondary data analysis, for example. That's usually where it starts. That's where it started for me. I had the opportunity to do a secondary data analysis for a PI. And I think if it wasn't for the way that MPH is structured, then yeah, definitely it would feel very like separated, walled off from students and PIs. But that was a good opportunity to sort of make that connection, and then it just grows from there.
All right, amazing. Thank you so much.
Your question as well, because I started out, as a graduate of UCLA as well. And I think it's really finding mentors that want to build you up. And so you need to
Mhm.
find people that really want to build you up and bring you up. And not everyone is a great mentor, I have to say. So I've had, we all have, right? And so I think you need to work with people that want you to develop your experience and your skills and build you up. And so that's really key in finding a mentor. And you can also interview your mentors. I mean, you can also don't just take the first person that comes to you. Really consider, like, is this person going to open doors for me? Is this person going to help me out to achieve what I want to achieve? I think Daya, I think, is that your name? Daya also has a question for me individually, just asking about my tips or lessons working with different populations. And I would just say that it's important to work with the community, hire from the community, hire your staff from the community, have a community advisory or a group that can advise you about your research or your intervention, and then give them feedback when the when your study is done, about what worked, what didn't work, and pay people for their time. Don't assume that when you come in that everyone is going to be a volunteer. So pay your community advisory board, pay your community workers, make sure that you build them into your budget. Any other
Can I also just
questions?
add to that? Sorry, can
Okay.
I also just add to that comment earlier? I mentioned it's really important to have people who believe in your work, and like Devora said, like interviewing and finding that mentor. Um, so Devora didn't actually start out as a mentor. I was just employed in the team. It was just a standard job. Um, it was completely out of her own will that she wanted to mentor me. There was no obligation or requirement that that relationship needed to happen. So it's a lot, also a lot of personal relationships, which yeah, I'm really appreciative for.
No, we work well together, and I saw that in you. But I try to give everyone that I work with that opportunity.
Yeah.
And some people don't want to be mentored or don't want to progress, and some people want to have different career paths. But I think Kalisha is a perfect example of like a really strong collaborative relationship that we've developed over the years. Yeah. I will share the slides so you can read all the references at the end if you're interested in learning more. And Kalisha and I are available if you want to pick our brains for anything else in the future.
Sorry, I had one quick question.
Yeah.
Um, so because HIV risk is so multifactorial, like you showed on that slide, are you collaborating with any other organizations to address those, like harm reduction for substance use or things like that, to just amplify the impact of PrEP as a preventative?
Yeah, no, it's a great question. We've done a lot of work with like biology, biologists to do some of the work on the microbiome to understand, what happens to the vaginal microbiome, for example, which is I'm an epidemiologist, and so Kalisha's an epidemiologist. So we collaborate with those sorts of, the people that do the biology and the lab science. We've also collaborated with people in the community doing work, especially around alcohol use and pregnancy. So I have another grant that Kalisha is not part of, that's working to address alcohol use and HIV in pregnancy and working with harm reduction organizations. There's just not very many. We don't have as many resources as we do in the US, unfortunately, especially outside of the city. So in Cape Town's a city, outside of Cape Town, there's very limited resources, but we're finding people, and we're going to have an intervention, a mentor mothers, peer intervention to reduce substance use in pregnancy and to improve ART and PrEP use. So yeah, it's a great question. It is really multifactorial, and I think we really try hard to think about what are the other things that we can do. We did have a social worker on our team that we would refer to help get help with intimate partner violence, especially if the woman wanted to leave her partner or if the police were involved. And so there was a lot of things that we thought about as how can we make sure to address all of the various issues, not just the HIV in women's lives.
Thank you.
Great question. So I think that Elizabeth sent a post evaluation. We would appreciate it if you can complete the post evaluation in the chat to give us feedback on the session and what we can do to improve. Haley, do you have any questions for us? Or Julia?
I think,
Oh, no, Julia. Go ahead. Julia already asked.
okay, sorry. My question, just kind of to wrap things up too, would be what is your greatest advice for UCLA students who are interested in global health and engaging in the work that you do to try and get more involved, whether it be through the pathway or just other experiences like the clinical electives later on?
Yeah, getting involved in the pathway with the global health program is great, and trying to do a discovery program in the field. I think that the best success that I've had with students going through the pathway are students that engage early on in MS1 or MS2, and we start getting involved in research. They have a better understanding of the team dynamics, they get a better understanding of the study, instead of just coming in on discovery and just starting to work. And so I think that there's ways to collaborate early on. I'm working with Victoria. Do you know Victoria? I think she's MS2. So she approached me and was really interested, and she's been supporting some data analysis with our team, and she's part of our team. So when she arrives, people are going to, be excited. So I think that the collaborating early will be really key. I know your time is really limited, but I think she gives us like 2 hours a month or something, a couple hours just to get to know the team and the research. So it's not just on paper that she's working directly with my team in South Africa, which is really key to get kind of that collaboration started early. And in anything, even if it's outside of GHP, is you want to build relationships with the team on the ground early on to build that trust. I don't know, Kalisha, do you have anything else you would recommend?
No, I can't recommend anything for UCLA students. Sorry. I'm not sure.
Yeah. Any other questions? Thank you everyone for your time. Have a great day. Kalisha, thank you for being here with me. I
Yeah,
appreciate
thank
it.
you. Thank you everyone for your time and having me.
Okay, thank you. Take care, everyone.
Thanks. Bye.
Thank
Thanks.
you.
Bye.
Thank you.